As we've discussed repeatedly here on Healthcare Triage, it's better for patients to have Medicaid than to be uninsured, contrary to what critics of the program might claim. But is having Medicaid, as those critics also say, much worse than having private insurance? That's the topic of this week's Healthcare Triage. This idea that private insurance is always better has become a talking point for conservatives who back big changes to Medicaid, as the Senate health bill proposed. The poor would benefit simply by being ushered off Medicaid onto private insurance, they write and say. But it's far from proven that Medicaid is worse than private insurance. A lot depends on what kind of insurance is compared with Medicaid and how they are compared. Many studies that measure Medicaid against private insurance suffer from the same flaws that compare Medicaid with being uninsured. They're terribly confounded and can show only associations. People with private insurance tend to be healthier and wealthier than those on Medicaid, and in ways not fully controlled for in statistical analyses. These factors almost certainly predispose someone on Medicaid to have worse outcomes than someone with private insurance. Perhaps the most convincing way to compare Medicaid and private insurance would be with a randomized controlled trial that pits them head to head. No such trials exist. Recall that the Oregon Medicaid study randomly offered, via a lottery, the opportunity for low-income adults to enroll in Medicaid. It did not have another study arm that offered private insurance. But we do have a decades-old trial that looked at varying levels of cost sharing, and we've talked about it before, the RAND health insurance experiment. This is relevant because one substantial difference between Medicaid and most private coverage is the level of cost sharing. Medicaid is nearly free. Most private coverage comes with deductibles and copayments. The RAND study randomized 2,750 families to one of four health plans. One had no cost sharing whatsoever, kind of like Medicaid. The other three had cost sharing, or money people had to pay out of pocket for care, at levels of 25, 50, or 95%, capped at $1,000 at the time, which is about $6,000 today. This level of personal liability acts like a deductible, making the plan with a 95% level of cost sharing comparable to a bronze plan on the Affordable Care Act's exchanges today. The RAND study found that the more cost sharing imposed on people, the less health care they used, and therefore the less was spent on their care. This study also found that overall, people's health didn't suffer from lower healthcare use and spending. Lower spending and no decline in health? These are the results that everyone cites to justify increased cost sharing, as well as shifting people from Medicaid to private plans with high deductibles. But the results of the RAND study, like so much in healthcare, are complicated. A deeper dive into the data shows that people decrease their consumption of necessary healthcare in equal measure to unnecessary healthcare. As a rule, we're terrible discriminators of what care is needed and what's not. Since most people under the age of 65 are healthy, even in the RAND study, that doesn't matter much. But even if most people are healthy, some are not, and particularly those on Medicaid. In the RAND study, poorer and sicker people, exactly the kind more likely to be on Medicaid, were more likely to die with cost sharing. The relative risk of death in the sickest quartile of people compared to the average participant was 1.9 in the free care plan and 2.11 for those in cost-sharing plans. Free care also resulted in improvements in vision and blood pressure for those with low income. To quote from the 1983 New England Journal of Medicine paper, free care does make a difference. One limitation of the RAND study is its age. It took place between 1971 and 1982. There have been no studies of cost-sharing that rival it since. Still, the best, more recent evidence we have is that giving care for free to poorer and sicker people improves health and saves lives. It is reasonable to conclude that switching them to a plan with high cost sharing, even a private plan, would do the opposite. Some of the more recent studies were nicely summarized in a paper by Catherine Swartz for the Robert Wood Johnson Foundation Synthesis Project. She found that increasing cost sharing for low-income populations was associated with the shift towards more costly services, like increased emergency room visits because people skip taking their drugs. She also found that increased cost sharing affects poor people differently than everyone else, confirming RAND's HIE findings. A more recent study found that enrollment in plans with high deductibles led to reductions in necessary care, which would have consequences for the poor and sick. Friend of the show, Austin Fract, has written previously, and we discussed here how increased cost sharing may lead people to take fewer drugs for their high cholesterol, hypertension, and diabetes. In my very first Upshot column, I wrote that parents delay taking their children for asthma treatment when cost sharing rises. Even small premiums can lead to problems, as we've discussed here. A $10 increase in monthly Medicaid premiums was followed by a 6.7% reduction in Medicaid and CHIP coverage for people just above the poverty line. Unquestionably, private coverage can work very well for many people. Take me, for instance. The insurance that I have from my employer is probably better for me and my family than Medicaid would be. Though my plan comes with cost sharing, I have an income that can handle it. My plan covers things that Medicaid often does not, like dental checkups. My plan is a great network, and it reimburses well for the care we receive. Just like Medicaid enrollees, I also receive support from the federal government, which waives tax collections on dollars contributed to premiums. That tax break is higher than the cost of Medicaid in many cases. Me and my family are also relatively healthy and would probably be fine on any plan unless and until our health deteriorates. But because my plan requires considerable cost sharing, even Medicaid enrollees would struggle on it. More importantly, neither House nor Senate repeal and replace bills offers poor Medicaid enrollees plans as generous as what I've got. The Senate's healthcare bill, for example, offered much less generous plans. A 64-year-old woman with an income of $11,400 a year would face a deductible of at least $6,000. For her, such a plan is not better than Medicaid. It is likely much worse if she is also sick. Because of the deductible, the care she'd need would be financially out of reach. A recent paper in Health Affairs documented that outcomes in Arkansas, which allowed poor people to buy private plans in the exchanges, were similar to those in Kentucky, which expanded access to poor people through Medicaid. But those private plans came with significant cost-sharing subsidies, which will be stripped away by the Senate's bill. Even so, the evidence did not suggest that the private coverage of Arkansas was better than the public coverage of Kentucky. There are certainly private plans for poor and sick Americans that are better than Medicaid. But plans with very high cost sharing, which are the ones being offered in Congress as ACA replacements, are not among them. Hey, I've got a book coming out November 7th. It's called The Bad Food Bible, How and Why to Eat Sinfully, and it comes from a lot of the episodes you've loved here at Healthcare Triage. I'd really appreciate it if you pre-order a copy. Links down below. Healthcare Triage is supported in part by viewers like you through Patreon, a subscription service that allows you to support the show through monthly donations. We'd especially like to thank some of our biggest helpers, including Sam, Joe Sevitz, and Joshua Crow. Thanks, guys.